Hi, everyone. So as most of you know, our mission at FARF is focused on finding effective treatments and a cure for Fanconi anemia. You also probably know that FA research is not possible to conduct or fund without participants. So this session is primarily meant to spotlight just a few opportunities for you to participate in ongoing FA research. Speakers will briefly be discussing their studies and providing information on how you might get involved if you're interested. So back with us again, we have Dr. Blanche Alter from the National Cancer Institute to discuss her long-term inherited bone marrow failure syndrome study. Welcome back, Dr. Alter.
So what I want to describe is the study we have at the NCI involving patients with inherited bone marrow failure syndromes, particularly Fanconi anemia, although we deal with others as well. For those who have not been there, this is an aerial view of the NIH. And this is our office, which is a mere 11 miles from the NIH, which is great, except as you know, I haven't seen my office in a while. This is the Children's Inn at the NIH where you would be able to stay, were you to be able to come. And now I'm at my home, which is about 5 miles from the NIH and about 7 from my office. So whatever the distance, once we get back to traveling, we'd really like to see people. This is a cartoon I've shown before. It was so typically brilliant of you to have invited an epidemiologist. Well, that's us. So what are the studies we do? We do natural history of cancer and genetic epidemiology, and that is funded through the NCI. We have been studying cancer in carrier relatives, and that's being wrapped up now. We've done a study in cancer in non-Fanconi breast cancer, and through the FARF, we have trained a Mexican physician that I referred to this morning. So our study on Fanconi genes in familial breast cancer, as I mentioned, includes a series of Fanconi genes at very low frequency, if they're not BRCA1 or 2, but probably more than up to 2 to 5% of the cases. And the relative risk is 8-fold for the PALB2 FANC-N. So the Fanconi BRCA repair pathway, which is the way it's termed, does include people who don't have Fanconi anemia, but are carriers and have one germline mutation. Our cohort, which we began, I must say, long before the FARF's registry. It's a natural history study which focuses on the course of things over time. Epidemiology is, I'm still having problems with all these figures over here, and I don't know how to get rid of them. There we go. Epidemiology is some of the factors controlling the presence or absence of complication. Genetics is to determine the gene and the mutation. We don't specifically do treatment, we don't do transplant, we don't do a lot of clinical trials, but we can make referrals. And we evaluate patients and review their records. We do clinical research. Dr. Geary and I, between us, have many, many years of experience in bone marrow failure, particularly Fanconi. So we're happy to consult and give advice. It's better if you're enrolled in our study because then we can get a hold of your medical records. There's no cost to the family or the insurance, and in the past it was easy. It was all of North America to just get on a plane and come. That's something we have to negotiate at this point. Certainly people who can drive here might be more eager to visit. Okay. So we want to see patients with Fanconi, including the post-transplant or the post-cancer, or who have had neither. And we study the whole family. So we study the parents, the siblings, and any offspring. We have a telephone screener, we call it, which is an interview. Then a medical history form. We start with a family history form, and then an individual form getting medical history. Usually the mother, sometimes the patient, sometimes the father. We don't care who calls, they become the family contact who we ask to help us with these forms. We request laboratory data. We will confirm breakage either by looking at reports or ordering it if we have to. And if mutations are unknown, and nowadays most people come in knowing their mutation or their gene, but we will put you into our research pipeline otherwise. We involve all of the different specialties, many of which you've heard mentioned already this morning. I'll say for gynecology that the most frequent type of cancer is vulvar and vaginal rather than cervical. And we don't start quite as young as Dr. Davies suggested, but we do start with just examination and conversation before we offer full examinations. Some of what we do, we want to do once, others need to be done repetitively. And specific for the patient, we will do, if they haven't had one recently, a bone marrow aspirate biopsy and cytogenetics. We do a bone age X-ray, a bone density measurement, because we've learned that the women with Fanconi who go through early menopause have all of the complications, including weakening of their bones. We ultrasound the abdomen. We want to look at the liver, the spleen, the pancreas, and the kidneys to see where they are and how many there are. We do MRI brain mostly to see if there are structural abnormalities. So that often needs to be done only once, but if they're in the BRCA2 or PALB2, we recommend that more often. And we offer cancer surveillance, and we demonstrate how to do that if necessary. The issues are the types of cancer, the quantitative risks, the different genes, whether they don't make protein at all or they make a little bit, the physical appearance of the patient, the association between the gene, the exact mutation, the physical appearance, and cancer. And so far, as I say, we've learned a lot about BRCA2 and PALB2, and we offer and train in cancer screening. And the cancer risk in carrier relatives, as I mentioned this morning. So this is for relatives, and this is where, if we were in the same room, I ask you to tell me how many carriers are in this pedigree, and I'm going to give you a moment to think about it, and then I'm going to show you. There are actually 7. So there are the offspring, the siblings, the parents, and half of the grandparents. So for relatives, we want to collect information about cancer, or whether they'd had one or not, what it is and what the age was, parents, grandparents, children, siblings, and others. We're particularly interested in the gene and the type of mutation in the proband, and we need DNA to look at for mutations in relatives. And I'll acknowledge right now that 20 years ago, when we developed this program, we were not collecting DNA on grandparents, which is at this point a bit of a limitation because we don't have all the material we would like to have. So we have studied more than 3,000 relatives for more than more than 3,000 relatives have been studied in literature cases, and we've added substantial numbers. And so far, our data suggests that a heterozygote carrier of a mutated Fanconi gene don't necessarily have an increased risk of cancer. But I must say we have to exclude from that statement the BRCA2, D1 BRCA2, the S BRCA1, perhaps the N PALB2, where the parents of a child who has FA due to those genotypes may in fact be at higher risk of cancer. And so that needs to be considered in the genetic counseling. The limitation of our study is that we have incomplete information now on DNA and cancer from grandparents because the study has been open so long. So I would urge those who are doing the registry at the FARF to think this through and go back more generations than they think they need right now. And so from that point of view, it suggests that identification of FA genes with increased risk in relatives should lead to specific screening recommendations for these family members. Lack of data showing an increased cancer risk overall in the limited study where we don't know the genotype of everybody suggests that it's going to be low, but some of the genes are found in the non-FA familial breast and ovarian cancer world, and that we need to pay attention to. So what we need in general for our entire study is a lot of data. Think of us as your medical bean counters. We have the telephone interview called a screener, the family history questionnaire, the individual information questionnaire, which is a medical history form on the patient, the siblings, the offspring, and the parents. We haven't focused on the grandparents. And then periodic follow-up forms. And we really like those, but there's a very low return for your money, because often we'll get back a form with somebody writing on it, no change. And we'd like more information than that. Most of our data is what we call self-report. We do want medical records if we can get them. For example, if somebody reports a cancer, we'd love to see the path report. And we do want primary pathology material, bone marrows or tumors. So if somebody is going to the OR or having a procedure, we like to know about it with some lead time, so we can send out a box so that it can be FedEx back to us with what the materials we might want. And that's what the telephone screener looks like. So there are many questions, but I want to reiterate that I know you heard about bone marrow transplant. Not everybody needs a transplant, and that's a real problem. Can they finish school, get a job? Of course. Can they have a family? Yes. Aging complications, we're still learning about it. How can we find things early? How can we prevent? That's something we'd like to do as soon as we get back in business. How can we treat cancer? That's a conversation. And what is a healthy lifestyle for someone with FA? Not very different from the rest of us. And the risk of cancer in relatives we've talked about. And so we've mentioned this, but we're very interested because the literature that we've studied is all case reports who had cancer. So we're very interested in hearing particularly from families with BRCA2 or PALB2 who don't have cancer, but anybody. So we can learn what specific mutations are associated with cancer in those genotypes. As I said, we provide transportation, lodging, food, and everything at no cost, but not all families can come at the moment, not very many. But we want information from everybody, and when we open up the floodgates again, we'd be happy to see people. So we do a natural history study, cancer risk, cancer in relatives, and BRCA2 genotypes. And we do have a website, marrowfailure.cancer.gov. Please feel free to look at it, and that's on the brochure and on the website. Thank you.
Thank you, Dr. Alter. We don't have time for question and answers, but we have somebody that wanted to say thank you very much from Trisha Mitchell, that she was in your study and she had discovered, oh, Ian, I'm sorry.
It's her husband, yes.
I'm sorry. Yeah. Ian, you discovered a cancer that he had that probably would have gone undiagnosed or for a long time. So she says, thank you.
Well, thank her and thank Ian, because at the live meeting, he always stands up and says that that's what we did. But that's what we do. We do see all of the relatives, and that's something any study has to consider for this kind of disorder.
All right, thank you so much, Dr. Alter. I'm now pleased to welcome our good friends, Dr. Oinika Valor and Christina Krieg. Dr. Valor practices at Children's Hospital in Newark, Germany, and is here to discuss her research on early detection of head and neck squamous cell carcinoma and Fanconi anemia. Christina is a FA parent and executive director of the German FA Research Fund and Support Group. She works very closely with Dr. Valor on research aimed at reducing the burden of squamous cell carcinoma and FA. Thanks so much for being here with us, you guys.
Hello.
Yeah, hello. Warm hello from Europe. So back to the whole world. And we are happy not to only join you in digital, but also give you a little bit of the flair of the feeling of sitting in the room and listening to our lectures. Christine, maybe you also want to introduce yourself.
Yes, I was introduced, so I'm the new person behind Ralph, or in the front of Ralph right now. You know Ralph since ever. He's in the scene, and I'm the new ED of the German group, and I'm very happy to be part of this very important topic of mouth cancer, because our son Lucas died of this cancer, and that's why I'm let's say, already addicted to this topic like Ralph was and is, and also Onika and a lot of you are also. So nice to be here.
Okay, let's begin. At this virtual Camp Sunshine meeting, of course, we will miss a few things. We will miss the nice surrounding. We will miss Ralph. We will miss some German chocolate, but we will not for sure miss the connection. And it is really a very good opportunity to be also connected digitally. So we want to share some of our experiences. Most of you who attend Camp Sunshine know already our study, so we want to introduce the study that we have done now for the last 14 years. And we also would like to share some of our recent findings, which have been published in the beginning of this year. I want to repeat and to echo some of the things that have already been said today. But for me, this is very important. Fanconi anemia affects the whole body. It is not only a blood disease. Some of your children and yourself know that you can have these café au lait spots. Some have physical anomalies like missing thumbs. And you can also get problems in the mucosa, so in tissue that is in the oral cavity, or also in the esophagus and in the anal region. So Fanconi anemia affects the whole body, and when you do a bone marrow transplantation, you only get rid of the problem in the blood, or the rest of the issues are still there, and that's very important to think about, because you are not cured from the complete disease, you are only cured in the blood. And we need to talk a little about these cancers, because they are life-threatening, but not in all age groups. This is especially for the adults, but compared to the average population, Fanconi patients seem to be much younger. So yesterday I received a call from a gynecologist, and she said she was really shocked by the diagnosis of a vulvar cancer in a 33-year-old woman, and she said normally this should be a cancer in the 60s. So that is something to keep in mind when you go to regular visits. The doctors should and must be aware of that you can get these cancers at a much younger age, even if you don't drink and smoke. And for the adult Fanconi population, these cancers in the past have been the major cause of deaths, and that's why we want to change. And unfortunately, it's not only that we are talking about one cancer, so these cancers seem to come back very frequently. This is what we call local relapse, but sometimes Fanconi patients also develop cancers at multiple sites, for example, in the oral cavity and in the anogenital region. And the treatment is really difficult. And on Monday, we have a large topic on that, and you will hear from some world experts about how we treat these cancers. So I don't want to go into detail in this. So mostly these cancers in the past have been made at late stages. And that's the most reason why these tumors in the past had a poor prognosis. And this is not only true for Fanconi. When you look at these data from the general population, when you're diagnosed with a small little tumor, your survival is very nice and very good, but as soon the cancer is large and has metastasis, the prognosis is poor. And this was in the past, unfortunately, very true for the Fanconi population. More than 50% of all these patients have been diagnosed with the stage 4, which is really a poor prognosis. To understand what we have been done, I want to go a little bit into the detail how cancer develops. This is important because cancer does not appear and develop from one day to the other. It has always a history. So far, we do not know how long this time takes, but it seems that it is some type of time. So this is a normal mucosa, like you see, here is where we eat things. This is the upper layer, and this is where the cells start to arise. And very frequent, we have little changes in these cells, and this can be repaired, and so this is a back and forth. But when these changes are not repeated, then these cells can get a growth advantage and they change. And this is what we call, when we see those changes under the microscope, mild dysplasia. And they can move on to moderate dysplasia. So the mild dysplasia can be cured by the immune system, but the moderate dysplasia, especially in Fanconi anemia, is already something what we don't like to see. And especially the severe dysplasia is something what we call point of no return, which ultimately leads to carcinoma in situ, which is a carcinoma that is so far not spread, not metastasized, and then of course the invasive carcinoma. So we can diagnose all these stages. We can do molecular analysis where we screen the genes, or we do cytopathology analysis where we look at the cells. We can use for all different types of studies here brush samples. And yes, we have been able to publish these results in 2015, and most recently in this year also our findings about the cytopathology reports. So here you see Christine entering last year Camp Sunshine for the first time. So we want to show you some of our results from the large study. We have been able to include within 12 years 713 patients. Out of these patients, 297 patients showed visible oral lesions. So we have done, as many of you know, this inspection of the oral cavity. Mostly I was inspecting the cavity of the patient and not the patient my cavity. So when we saw a lesion, we marked this lesion on the mouth map, and we took a picture with our endoscope system. We brushed the lesion. We brought the samples to Düsseldorf, and the written report, including the mouth map and the picture, have been sent to the patients. So the big question is this brush accurate enough to diagnose lesions at risk? And I don't want to go into detail, but I want to show you first of all that oral lesions seem to be very frequent, and especially the older you are. So we have seen 1,230 lesions in 297 patients. But if you are transplanted, the chances to develop these lesions are a little bit higher than when you're not transplanted. And some people ask, when is the age to start for screening? You see, at the age of 10, you should get the screening, because then people start to develop these changes. So when we talk about how good is the test, we want to have a high sensitivity and a high negative predictive value, so that we don't miss a positive case and we don't misdiagnose negative cases. And we have been shown in our population that these numbers are really high. And when we add to the pure cytology another technique, we can nearly reach up even to 100%. So that means that this brush biopsy really has a high diagnostic accuracy. So what we have learned, these lesions are common. Most of the lesions are not malignant, so they are just sitting there doing nothing. And oral brush biopsies with these little brushes seem to identify these lesions that are really the risky lesions. So you do not need to biopsy all these lesions. And this is an example of a patient, 12 years of age. The brush was negative. 1 year later, the mother sent us this picture. The lesion was biopsied and it was negative. Then we saw the patient back again at camp in 2018, and the lesion was brushed, came back positive. The biopsy was an excisional biopsy where they cut out the whole thing, and there was a 1 millimeter cancer in the middle sitting here. So even the cancer was very little, the lesion itself was big, but the brush was able to detect the 1 millimeter cancer. And already 4 weeks after the surgery, look at that nice result. So that is really an enormous benefit. So we have been able to show that this brush technology really works, has a high accuracy, and that invasive biopsies, so really cutting out things, can be reduced to the ones where we really need it, to 75% have been reduced. And I will show these data on Monday. Most of the cancers that we have detected have been at early stages, and patients are doing very well, like the patient I just showed. So what are our next steps? Yes, we can use the brush, so we need to implement this technology in a screening program, and we have to empower our patients to fight for themselves, and therefore we moved forward. We asked FARF for an additional continuation of our project, and we really are very thankful for FARF to supporting in the next 3 years with a lot of amount of money, so that we are able to implement this brush in the daily routine, that we analyze the data of the patients we have seen, that we reuse old material. And Christine, you want to share something about how we want to empower our patients.
Onika, maybe you just stop sharing your screen if it's possible. Okay, so I just want to show you, we have, okay, that's not working, isn't it? The problem, oh my God, it's not working. Okay, we have the problem, we have a high risk of cancer. Can you see that? And we don't want to look at that. Not as a parent and not as an adult and nothing. We don't want to look at it. And we're used to give the doctor, he is the big hero and has to solve the problems, right? But the doctor, he's blind. He
Christine,
can't... Yes?
hold it up to your face.
To my face? Oh, thank you. That's nice. I restart. We have the problem of cancer. Sorry, that's nothing to laugh about, but the situation is funny. So, and nobody wants to take a look at it. We usually give our power to the doctors and not to ourselves. But in this case, the doctors, they are blind and can't see anything. So we need a change, okay? The situation today, why isn't this working now? Alexander, why isn't it working? Okay, now it's working, isn't it? Okay, the problem
it'd be better without a background, Christine.
Yeah, that's right. The next time without Camp Sunshine in the back. So we had the hope, and now we have the knowledge today that early stages have a very good outcome. And also we know that the brushes work. This is really, really, really a good thing we have right now. But it can be better, right? Because we still have the other problems we were talking about. So our tomorrow, starting today, will be for you as a participant to learn everything you can learn about this whole deal, the whole cancer and everything, to take self-responsibility and to become experts. So this is what we mean with self-empowerment. You have to be able to train your physician. He's still blind, he will be blind, and if we wait till the system gives him more knowledge, then it takes another 20 years or something like that. So we have to take action and have to change things. And the pillar C, which was on the graphic of Onika right now, is about learning. So what does this mean? So we will prepare graphical material like brochures and paperwork. We will prepare teaching videos for you for a self-examination, but also you can watch videos for taking brushes. Of course, we want to train you as an individual also, using our system, talking together, looking at pictures, looking at your own mouth and trying to find out how things work. And also we have planned to develop an app to connect better document. Yeah, the different stages of your mouth and so on. Yeah, and the big, oh God, the words are gone right now. So the big aim we have is to connect us together with good doctors. So this is a big part of Pillar C, which Onika just said. So this is a lot of work to do, and we will do it. Onika, your turn again.
So, and we are very happy that we can be able to do that with the help of FAF, with the help of you. And this is very important because it is a worldwide approach. So we will not be able to do a personal inspection. So we really need you and your information. So if you have private questions that you do not want to ask in the Slack line or also now, you can all sign in for Ask Dr. Felloyer on Monday morning, so that we can have a little bit private discussion on maybe things that you want to share with us. So thank you everyone for participating in the past and in the future. Together we really can learn from how we can reduce this burden.
Right. Thank you so much, ladies. We really appreciate you being here, and we're so grateful for all the research you're doing. Next, I'd like to welcome Dr. Agnieszka Czekowicz and Dr. Rajni Agarwal-Hashmi from Stanford University, and Dr. Wendy Peng from Jasper Therapeutics. I apologize if I got any of your names wrong. Hopefully they're right, but they'll be sharing information on the Stanford Antibody Conditioning Stem Cell Transplant Trial. Thanks so much for being here with us.
Thank you so much, Jordan, for inviting us and for the entire bringing this all together. Today, I was hoping to tell you about our program here at Stanford, and specifically about our Stanford Antibody Conditioning Trial that we hope to launch this year. Just give me a second to try to open the slides. Can you guys see those okay?
Yes, we can see them.
Perfect. So I'm joined here today by my colleagues Rajni Agarwal, who's one of our senior clinicians here at our Stanford Children's Transplant Program, as well as one of my colleagues, Wendy Peng, who is now at Jasper Therapeutics, which is the company that is advocating for further development of this antibody conditioning. So just before I launch into the trial, I wanted to give a little bit of an introduction to our Stanford Children's bone marrow failure program, and in particular to our FA program. So we have quite a number of clinicians here within our program, both on the stem cell transplant side, as well as on our hematology side, that work together to help care for an advanced center for definitive and curative medicine that is working on revolutionary new treatments to really help promote new ways of treating complex diseases. And it's the combination of our coordinated care program through our bone marrow failure program and our Center for Definitive and Curative Medicine that have been able to put together these innovative trials that we've launched over the last couple of years. In addition to this, we have a number of subspecialists that work with us in each of the various different organ areas to help support care for our patients. In terms of what we're doing for FA, we have a number of developments in progress. We are concentrating our efforts on optimizing grafts, on optimizing conditioning for transplantation, as well as for developing new ways to protect the remainder of cells. In terms of our programs on optimization of grafts, we have some extremely exciting technologies in development. One is our alpha beta T cell development depletion program that we've been running for quite some time now here. That's led by Dr. Alicia Bertaina, who's not joining us today, but is really a superstar in this area. She led the program with Dr. Locatelli in Italy for many years and has done over 450 alpha beta T cell depleted grafts. We also have a gene therapy program for patients pre-bone marrow failure who specifically have defects in the FANC-A gene that we'll be talking more about on Monday, that is run in collaboration with Rocket Pharma and colleagues across the country and across the world. But today I'd like to focus our efforts on our program on optimizing conditioning for transplantation. So as was spoken about earlier today, prior to receiving a transplant from a donor, patients first need to be conditioned. Classically, that is done with irradiation and chemotherapy. However, we've been working on approaches to eliminate the need for that and instead use antibodies. What I won't talk about today is our additional efforts on working on protecting the remainder of the cells in the body, not specifically just hematopoietic stem and progenitor cells or the blood and immune cells, but also the other cells of the body that are affected by FANC mutations. And Dr. Ken Weinberg in particular is leading these efforts, and hopefully you've had a chance to hear about some of this in past meetings, but we'll be talking more about this in future meetings. So really, what are some of the issues with Fanconi anemia? Well, historically, we know that many patients unfortunately develop bone marrow failure with this disease and also have other problems with their hematologic system. And so our goal really has been to treat early and to try to protect this blood and immune system to really prevent malignancies or other issues which can occur. And these are actually accelerated in traditional transplants. And so our goal has been to make the transplant process better to really eliminate this bone marrow failure and hematologic malignancies and try to prevent the secondary malignancies or solid tumors that sometimes patients receive. And so we have two main approaches here at Stanford that we've been working on to treat that hopefully protect the blood and immune system as well as reduce or eliminate these additional tumors. Like I mentioned, there's these two innovative treatments that we're primarily focusing on right now. One is the gene therapy that I mentioned that we'll be speaking about on Monday. And then the other is using this antibody conditioning approach, and specifically using an antibody to CD117, which is a marker on stem cells. And this program can be used for all patients with Fanconi anemia, whereas the gene therapy, unfortunately, is restricted to those with only mutated. In collaboration with Dr. Agarwal and others at our center, as well as Dr. Pang and others at Jasper Therapeutics, we've been working on putting together this phase 1/2 trial that we hope to open this fall, that is combining this novel type of antibody-based conditioning with these alpha-beta T-cell depleted grafts that we've shown over the years are extremely effective at reconstituting the blood and immune system. The sponsor of this program is our Stanford Center for Definitive and Curative Medicine, and particularly Dr. Maria Grazia Roncarolo, who has been a decade-long leader in cell and gene therapy. And Dr. Agarwal and myself are the clinical PIs of the study. We hope to launch this study earlier this fall and anticipate enrolling about 12 patients over time. Initially, we are anticipating this study to only be run at one center here at Stanford due to the complexities of making sure all of these pieces come together well. But over time, hope to be able to expand this program to many other institutions to make it more accessible to others. And so what is this trial really all about? Well, it includes investigational products. One is the alpha-beta T-cell depleted donor grafts that were mentioned about earlier today. And the other is this antibody-based conditioning, and specifically this antibody against CD117. This drug was previously called AMG 191 as it was developed in partnership with the company Amgen, and has now been renamed JSP 191 and is being led by efforts at Jasper Therapeutics. And the goal is really to combine these complementary discoveries to really transform the treatment of Fanconi patients, to really try to treat and prevent bone marrow failure in all these patients in a safe way. The alpha-beta T-cell depleted grafts are thought to be able to decrease the graft versus host disease component significantly and enable more rapid blood and immune reconstitution to really prevent infections and to prevent these serious complications of graft versus host disease, which are even worse in Fanconi patients. And as I mentioned, this technology was developed in part by Dr. Bertina, who is helping co-lead the study. And then the other component is the antibody. The goal of this antibody is to replace busulfan conditioning and irradiation that is used in many Fanconi protocols, and to enable engraftment of the stem cells without those genotoxic agents. And this is a technology that was developed in part by myself, Dr. Pang, Dr. Shizura, and Dr. Agarwal. So there's now significant data on both of these discoveries in patients, and the goal of this trial is to combine them. In terms of the alpha-beta T-cell depleted hematopoietic grafts, these are not new. As I mentioned, my colleague, Dr. Bertina, has again transplanted over 450 patients with these transplants. And this is just some data that she shared with me of the transplants that she has particularly done in Fanconi anemia. Now, these are patients that actually had and actually were taken to transplants using haploidentical or half-matched donors. And in these Fanconi patients who received these alpha-beta T-cell depleted grafts, they had excellent outcomes. They had, in all of the patients that they treated, complete survival, and only one of the 10 patients developed graft versus host disease. These are special grafts that eliminate the alpha-beta T cells that cause graft versus host disease, and instead contain the gamma delta T cells and NK cells that help with engraftment and fight infections. Usually these are done when there are no other donors that are available, and again, these half-matched transplants like the data that is shown here. but these can also be done with better matched transplants. And so the goal for this trial is to include these grafts that have already proven to have efficacy together with the antibody. The antibody conditioning is a program that we've been pioneering here at Stanford for over 10 years now. Again, the goal is to eliminate the classic ways of doing transplantation by eliminating the chemotherapy and radiation that patients receive, and instead use the hematopoietic stem and progenitor cells and leave everything else intact, both in the bone marrow as well as in the other tissues of the body. These are extremely specific methods that have no genotoxicity, so decrease both the short-term and long-term complications. And in particular, this one antibody that I mentioned, known as AMG 191 or JSP 191, has been shown to be safe and effective in both non-human primates and in patients. In the non-human primates, when it was tested at even extremely high doses, no toxicity was observed. We showed a very specific depletion of the non-human primates' stem cells. This was then taken to a clinical trial in patients at our institution that Dr. Agarwal led. What we were able to show is that in these patients that were treated with severe combined immune deficiency, they were able to have depletion of their stem cells and engraftment of their donor cells. And this is just some of the data here in the 9 patients that were treated to date, 6 of which we've had longer term data. And what we've shown that this is, again, extremely well tolerated with no side effects, and that we start to see engraftment of donor cells. In this system, these patients have no immune system, and so this was given as a single agent with no additional drugs. But in the Fanconi patients, because they do have an immune system, we would need to still use some immune suppression to eliminate the immune system to not have immunologic rejection. So given these 2 exciting discoveries of the alpha-beta T-cell depleted grafts and the antibody conditioning that, again, have been used in many patients now, showing both safety and efficacy, we've designed this study for Fanconi anemia patients, where we're combining these 2 agents along with standard immune suppression to eliminate the potential for immunologic rejection, which consists of these 3 medicines, ATG, fludarabine, and low-dose cyclophosphamide. And our goal is that by combining this antibody with these medicines, we're able to eliminate the need for total body radiation and busulfan that's used in other protocols, which hopefully will both decrease the short-term toxicities of this transplant process, minimizing the amount of time that patients stay in the hospital and the potential complexities, as well as prevent long-term issues such as the secondary malignancies that unfortunately are all too common in FA patients. Again, this type of transplant would be open to all patients with Fanconi anemia, regardless of the type, but we're hoping to start with first patients that are in bone marrow failure that are really requiring bone marrow transplants to stabilize and return their blood and immune system. Although if this shows extreme safety and efficacy in the future, we may even do it prophylactically for patients with normal blood counts. So that's where we are right now, is in the planning stages of this trial, but we're making advanced progress with being able to bring this to patients. Again, we hope to open this trial in the fall, start enrolling patients and treating them with these 2 drugs that have already been used in patients in combination with standard immune suppression. And if you have any questions or want further information, we're of course more than happy to speak with you about that or any of the other types of treatments available here at our Stanford Children's Program. And with that, I'll open it up for questions.
Okay, thank you very much. Exciting news. We've been answering questions, typing answers to questions as we've gone along, but we don't have any new questions for your session, which I'm surprised. So thank you very much.
Good, I must have been extremely clear.
That's it.
As I mentioned, we're extremely excited about being able to offer this treatment for FA patients. We know that there's been decades of work, both at our institution and others, that have really worked to improve transplants in many different ways through the current medications that are used and the current ways that grafts are manipulated. But we think that these additional approaches will further really improve outcomes for FA patients, and especially given what we've seen in other settings. And we're extremely excited about this approach. Dr. Agarwal, do you have anything else to add?
Thank you very much. Thank you.
Thank you for the opportunity to share the trial.
Yes, thank you for being here. We actually had a few
Yes.
questions pop up. Jordan, do we have time for a couple? Are you?
You could do like 2 minutes. Yeah.
Okay. Okay. So one of the questions is, does this process apply for sibling donors as well?
So because sibling donors have excellent outcomes without the need for busulfan or irradiation, right now we're opening this trial only to patients who do not have sibling donors who would need unrelated donor transplants or haplotransplants. But it could be all the way through haploidentical transplants.
Okay. And another question is, are people outside of the US eligible for the study?
So
and what are the criteria for the eligibility?
Yeah, so the goal is to be able to have this study available to all people who we think would benefit from it, which is anybody who has Fanconi anemia, who is starting to show signs of bone marrow failure. Likely our eligibility criteria would be similar to when we decided to take other FA patients to transplant, so starting to show some signs of cytopenia, but we're still working with the regulatory agencies on really fully fleshing out what those eligibility criteria are. Also, we likely would first start with patients who do not show signs of myelodysplasia or leukemia, as those patients probably would still benefit from higher dose chemotherapy initially to make sure that those abnormal clones are eliminated.
Okay, and along with the eligibility question, is there an age restriction?
Likely that there would not be a significant age restriction. We're thinking of patients above the age of 1. Who is eligible should be able to participate in this study.
Okay, and I think we'll have time for one more. Does this prevent the need for any radiation or chemo altogether, or just simply reduced doses?
So our hope is that ultimately it eliminates the need for all radiation and chemotherapy altogether. Initially, we're still using some low-dose chemotherapy in terms of being able to provide immune suppression so that we don't get immunologic graft rejection. So it's still very low doses of cyclophosphamide and fludarabine, but the hope is over time we'll be able to take those out altogether, but we don't want to risk initial graft rejection. But we are completely eliminating the busulfan and the irradiation, which are used in other transplant protocols. And those are the two agents that tend to cause the most severe acute and long-term toxicities.
Okay, great. And one question, just so that I can allow everybody to have this, is that you can get information on this trial from our website, from the FARF website. It's under the patients tab, and there's a tab for clinical trials. So you should be able to find the information you need there with live links directly to the page.